Assalamu alaikum.
Waalaikumsalam, Doctor.
Good morning. How are you?
Good morning. We're good, Doctor.
Alhamdulillah, Alhamdulillah. Hoping all of you are healthy and studying well
Inshallah.
and reading enough about the personal protective equipments before coming, inshallah, to the hospital, so you will keep yourself safe, inshallah. Okay, how many candidates attending it today?
9, Doctor.
Is it 2 groups is 9?
Yes. Group 5 and group 6.
So 5 and 6 is equal to 9?
Yes.
Is it new math? Is it advanced?
What, Doctor? I'm sorry.
You told me it is 5 and 6. Now the attendants are 9.
Oh, no. From group 5 and group 6. We have 9 people out of in 2 groups.
Only 9 people.
Yes.
So رويدة or رويدة. Oh, فمهل الكافرين أمهلهم رويدة وإزتي فواز أفيكا أيدا أكيلا.
Yes, Doctor.
Good. And just إفت هداية ما شاء الله. Sharifa. Good. So today you prepared already two presentation.
Yes, Doctor.
Okay, who will be the first one to discuss?
Me, Doctor.
Okay, just start by Kitab and let us start.
Yeah. So is everyone ready? Sharifah Haja, I cannot see your face.
Okay.
Okay.
So I am a bit confused. Who will be the presenter?
We will be doing the role play. I'm gonna be the doctor and Sharifah Haja gonna be the patient's mom.
Okay, you are Fawaz?
Me.
Okay.
So we are going to start with our first presentation. So Assalamualaikum warahmatullahi wabarakatuh. My name is Daniel Afif and I will be acting as the doctor in charge. And here is Sharifah Haja. She will be acting as the mother of this patient. And in our group, there are also Nur Hidayah and Fawaz Naim, who will be in charge of differential diagnosis and also the OSCE questions for the first case. So, Puan Sharifah Haja, may we start with our session now?
Yes, sure.
So, for the first question, I want to ask, so what's brought your child in today?
Okay, so I brought him to hospital because of unresolved fever for 6 days and also rash for 2 days.
Rash for 2 days. And how old is your son?
He is 1 year old, 1 year and 8 months old.
Okay, so your son Haras, 1 year old and 8 months. He had a chief complaint of fever for 6 days and 2 days rashes. Am I right?
Yes.
Okay, so you said that he had a fever for 6 days. So can you explain briefly the chronology of the fever or other symptoms that he developed?
Okay. So He had fever 6 days prior to the admission. And he had with dry and fissured lips. He also had reduced oral intake and he was irritable. And then on third day of illness, I noticed that he had a progressive left neck swelling, which was pain to touch. And there was also chesty cough and also runny nose. So the next morning, I brought him to Klinik Kesihatan Rompin, and the clinic give antipyretic and also antibiotic.
So what happened after the clinic give the antibiotic and antibiotic? Did anything happen, or is it subside, or is it going constant, the fever?
Unfortunately, the fever does not resolve. And so in the evening, he also started to develop rashes. So
The rashes is due to allergy, or do you think it is related to the disease?
I don't think allergic, because he had not have any trigger or any factor that precipitate. I think maybe because of the disease.
Okay. Okay. Can you explain more about his rashes?
Okay, so in the evening, he developed rashes, and then I brought him to Hospital Rompin. So the rash start on the abdominal area, and then it spread proximally. The lesion was reddish, some raised, non-vesicular, and not itchy. I'm not sure if the rash is blanching or not. So I brought him to Hospital Rompin, and the hospital gave cefuroxime, the name of the antibiotic, if I'm not mistaken, and he was not hospitalized. So on the 5th day of illness, he also had an episode of vomiting after drinking milk, and an episode of diarrhea with green stool in the evening. Yes. And then he also had another episode of diarrhea with the same characteristic for the next morning. So the 6th day.
Continue.
Okay, so on the 6th day of illness, I brought him again to Klinik Kesihatan Rompin. So that's when he was referred to the hospital Pekan with suspicious of Kawasaki disease.
So you came from hospital Klinik Kesihatan Rompin and you went to Pekan. So other than fever, diarrhea, and also vomiting, were there any other symptoms that are serious were developed?
I think on the 6th day of illness, which is on the day of admission, the fever is still unresolved, and then he also had like redness of eye, and also yes, and peeling on his right thumb, and then his bilateral hand and also feet is like swelling. And then he also looked lethargic.
Okay. So we will going to move. I want to ask you more question regarding the past medical history. So does your child has any medical conditions or any history of hospitalization before?
Yes, he had 3 hospitalization before.
Oh,
So the first one when he was 3 months old.
3 months old.
Mm.
Is was due to what? Why did he came to
Uh,
the hospital?
uh, because of interception. Mm.
Or what did the management for what is the surgery? Did the
Uh,
Haras did any surgery due to interception?
uh, um, it was in HDA, and the
Hmm?
doctor give like catheter and also give like air pressure uh, for the
Or
interception. Yeah.
air insufflation?
Yeah. I'm not.
Oh, okay.
Yeah.
Okay. So what happened to the second and the third admission?
The second admission when he was 5 months old, admitted to Hospital Rompin for 3 days because of dysentery with blood streak stool in blood streak stool with mucus.
Oh, okay. So and the third one?
The third one when he was 8 months old, he was admitted to Hospital Rompin for 7 days because of bronchopneumonia. Uh,
Oh, okay.
and and he was given antibiotic and nebulizer for that.
Oh, for the bronchopneumonia, did the hospital do any intubation to him? Do he need
Uh,
any intubation?
no.
No. Okay. So the next question I want to ask, did your son has any drug or allergy history?
No.
No. Okay. So did your son complete his immunization schedule?
Yes. He followed the KKM immunization schedule.
Okay. So next, I want to ask about the birth history. So first, for the prenatal history, um, were there any obstetric problem, including abnormal antenatal scans or screen scan? I mean, the position of the baby, or it was uneventful for you?
It was uneventful. No abnormality detected. But I did have uh, diabetes, gestational diabetes mellitus, intrauterine infection. Mm.
Or did you have the hypertension due to the pregnancy?
Yes.
Or okay, so for the uh, birth history, were there any concerns during the delivery or any interventions required due to do the labor?
So Haras was born term at 40 weeks via vaginal delivery, and his birth weight was normal, 3.3 kg.
Oh,
He nothing, but he had neonatal jaundice for 1 day.
oh,
Mm.
so the Haras require a special baby care. And why did he get to why did he need you said that he had a neonatal jaundice, right? Why is that? Did he have the scleral jaundice or skin discoloration or any other symptoms?
Oh, it was actually just based on reading,
Mhm.
and he had no apparent yellow discoloration of skin or sclera, and
Oh,
does not receive phototherapy.
okay. And next, I want to ask about the nutritional history. What do Haras eat normally?
Normally, Usually I give for now I always give him porridge. Porridge.
Mhm. And before this, did you exclusively breastfed him?
Yes, for the first 3 months, and
Mhm.
then he was fed with formula milk until now.
Oh, okay. Um, Next, I want to confirm about the development history of your son. So for the is he able to run walks up down the stairs with your help?
Yes.
Uh, can he respond and know when someone calls his name?
Yes.
And for can he also give a hand sign movement like with bye bye or use a spoon? Well,
Yes.
okay. Next, I want to ask about the family history and the social history of your son. So, uh, has anyone else in the household experienced a fever recently?
No.
No. And uh, does your husband or you have any non-medical illness?
No.
Okay. Um, uh, what do you and your husband do for a living?
Okay, so my husband worked as an operator at Pengurusan Air Pahang. I work as staff nurse at Klinik Kesihatan Rompin.
Oh, okay. Oh, so both of you are currently working. So when you got both of you are working, where did you send her as?
We send her to a babysitter.
Hmm. So at the babysitter's house at the daycare center, did anyone experience the same symptoms as Haras?
No, I think no.
Okay. So so Haras has how many siblings?
He is the third out of three. And his older brothers live and well, no non-medical illness.
No similar symptoms as Haras.
Yes, no similar symptom.
Okay, so may I know how long does it took for you from your house to the closest clinic setting or any hospital?
So the closest klinik kesihatan is klinik kesihatan Rompin, and it took about 5 minutes to go there.
Oh, okay. Okay, I think that's all for the session. Thank you, Puan Sharifah.
Okay.
Doctor, may I summarize the case?
Yes, please. I need short summary, just 2 or 3 sentences.
Okay. In summary, Haras, a 1 year and 8 months old boy, brought to the hospital due to the chief complaint of fever of 6 days and generalized polymorphous rash. The associated symptoms are neck swelling, facial lips, strawberry tongue, non-purulent conjunctivitis, discoloration of right thumb, and also bilateral hands and feet swelling. There was no history of traveling, water activity, or sick contact, and uh, okay, that's all for the summary.
Okay, with a previous history of intersusception, and sometimes you need to document that. Okay, that with
Oh,
history of intersusception and no family history of allergy, because
okay.
some important point must be in the sense. Okay, so what is your working diagnosis now?
For the diagnosis, my proficient my provisional diagnosis is Kawasaki disease, because this patient had developed all 5 of the criteria for the diagnostic criteria of Kawasaki disease. The first one is bilateral non-purulent conjunctivitis, and next is mucosal changes, which is the stabilita, and also the changes in extremity, which is edema or erythema of hands and feet. The patient also has rashes on his body to the proximals, and also there is a cervical lymphadenopathy.
Okay, when did you suspect the peeling will occur with Kawasaki?
I'm sorry,
The peeling,
the peeling.
yes.
Maybe it is due to the skin erythema or due to dehydration.
When did you suspect it occur?
Or when I expect it occur. At the around the 5th day of the disease.
Usually it occur late, okay? Rarely to occur like that. So if it occurs, sometimes it will occur very late, and it will let us oriented that we may miss Kawasaki or like that. Okay,
Oh,
so what is the mechanism of Kawasaki disease?
mechanism of Kawasaki disease.
Yes.
So the etiology is not known, but there is a acute systemic inflammatory process in the blood. So it causes the inflammation in certain part of the body, especially in the arteries, such as coronary arteries.
So clinically, you can diagnose because you have settled the criteria now. Is there any important investigation which can support your diagnosis, Daniel?
For the investigation to support my diagnosis, the first one I would like to do the full blood count, because I want to look for uh, uh, the white blood cell, if it's infection, the bacterial infection or not. And next, I want to also do the CRP, because I want to check for the extent of the inflammation of the Kawasaki disease, how far the severity. And next, in Kawasaki disease, usually there is a rise in ESR, the inflammatory markers.
What else?
And also, I want to do
And the full blood count.
full blood count, CRP, and also I want to do the liver function test to assess if there is any hepatic manifestation. And also, I want to do the urinalysis, because in some cases, in a severe cases, there can be a pyuria in Kawasaki patients.
Yeah, I mean for the full blood count, we must search for thrombocytosis.
So, thrombocytosis. Okay.
It is very, very important. Of course, sometimes ESR, sometimes, as you said, it changes in the urine. It is very important, okay? So, Hagar, Sharifa Hagar,
Yes. Yes,
uh,
Doctor.
what did you suspect if you see this patient even in the emergency department or just admitted? What you, one important investigation and one important intervention you need to do?
I think to look for the complication of the Kawasaki disease, like the heart involvement,
So what you are going to do?
chest X-ray, and also ECG.
What else?
Echocardiogram and also echocardiogram.
In that situation, we must jump to echo, okay? As we routinely we will do the chest X-ray and the forelimb blood pressure and the ECG and echo. Okay, any emergency decision do you need to take? Regarding the treatment.
Regarding the treatment, we may include the IV immunoglobulin and aspirin as for the treatment for this patient.
So the IVIG must be established if you suspect. Aspirin usually related to the echo if there is heart, either clinically or echo changes. Okay, so IVIG is a very, very important one.
Doctor, I want to ask about the aspirin. They say that aspirin has so many contraindication or side effects. So do we still give the aspirin to the patient?
Yes.
Oh.
It is the same. Corticosteroid has a lot of side effects. Yes.
Oh.
But we must give.
Okay.
Even we must give in high dose. If nephrotic syndrome came to you said cortisone is a bad drug, it can cause many side effects. So better not to give and leave the patient until he got chronic renal failure or even die. It is not worth it. But the issue, how to adjust the dose, how to predict for the side effect, and take your decision. Okay. But if established that there is coronary artery aneurysm, you must start in high dose with monitoring of the blood investigation, bleeding tendency, clinically liver function test. All these are very important, but we must continue. Okay. No medication without side effect, in spite it can be different between people's, but even sometimes you are going to consider for a patient of leukemia immune drugs, which can cause a lot of side effect, can cause up to complete neutropenia, leukopenia, falling of hair, severe immune deficiency, but you must give. Otherwise, the patient can be killed. At least you can monitor, and in certain situation, you are able to take another decision to stop it for a while until the patient retrieve to decrease the dose, like that. Okay. So please, this is an important point which Daniel speak about. Yes, one of our job, like if I'm going to speak now to Hajar, I would like to tell her that your baby needs IVIG. IVIG to stop this immune disease. It may got some side effects because it is considered like blood product. At the same time, we need to stop the vaccination, especially the leaf vaccine, for up to 9 months. We cannot give the vaccine because at the time it will not work. Everything has its side effect, but in our practice, we are making a balance between the benefit and harm. And we can see that if the benefits are very high. Otherwise, if coronary and artery aneurysm didn't treat it by IVIG and to continue on aspirin, and we are going to continue aspirin until we tell you to stop. So we are going to repeat another echo after 6 weeks and another echo after 3 months until it resolves. Sometimes we may continue for a longer time. Okay, am I clear? This is
Yes.
very, very important. Ruwaida.
Do you mean Rauda, doctor?
Rauda. Okay.
Yeah, Rauda.
Because we have an Arabic name, Surah Al-Tariq, Ruwaida. Ruwaida is the word that came in the Quran, Surah Al-Rawda.
Yes.
That can be also. Rauda, the most important point, did you hear about some definition of atypical Kawasaki?
Yes.
What is this?
Doctor. It's Kawasaki symptoms or with atypical symptoms like renal disease.
What do you mean? We have now criteria, so
Criteria for atypical Kawasaki.
mm,
Coronary arteries abnormalities.
yes. So, I mean, if we found the coronary artery, we are going to diagnose even there is not complete criteria, and even I need to put how many criteria?
Mm, not is it 4 persistent fever?
Okay, so you need persistent fever and 4 or 5, or what is the criteria, Daniel?
Sorry.
Daniel,
Yes, doctor.
the criteria for diagnosis is?
The criteria for the diagnosis is there's a mnemonic for the criteria, which I would like to say CRASH. So C for conjunctivitis, R for rash, A for adenopathy, S for strawberry tongue, H for Hansen feet and Nash.
CRA, what you can write it?
CRASH, crash.
Crash. Crash codes. Good. Just to put it in after exudative tonsillitis, okay? Crash code. So to diagnose, you need the 5 criteria?
More than 5. But for the incomplete Kawasaki disease, it is persistent fever and fewer than 4 of the typical findings.
Okay, that is the point. Because that immune disease, sometimes it will not evolve on the same time and involving all the organs. So you must take care about that. And also, just to remembering you, there is sometimes another clinical findings. If you get a look to the BCG scar, you will find it edematous like that, okay? So that is the issue, to be aware of some emergency about that, okay? Of course, the child are very young, okay? But if you found some child now, the question may be for Fawaz, if you found a child now, like he's for 5 years or more, and he got also fever and some skin manifestation in the back, and also we found cardiac murmur. What can be the diagnosis, Fawaz?
Could be scarlet fever.
What is the relation of scarlet with the heart?
It can cause rheumatic heart disease.
Yes, this is a very important differential diagnosis of rheumatic heart disease. Usually Kawasaki will occur on a younger age. The recommended age before for the rheumatic fever is from 5 to 16 like that. But now there is documented cases of even neonatal or infantile rheumatic hearts because they found it also as a gene. So it is very important to consider if this child are a bit elder or school age, I must consider rheumatic heart disease because it's fever. There is also some skin rash. I may found the child they have remaining lymph node because you know for rheumatic fever, the patient needs to put tonsillitis. It may be 2 weeks ago. Maybe still there is some lymphadenitis, which is not so enlarged. Okay. All this as a result of group A beta hemolytic streptococci. So, what is the other criteria for rheumatic fever effect?
For the rheumatic fever, is it the 5 components?
Yes.
The carditis.
How can I diagnose a case of rheumatic fever? Your colleague told us now that there is criteria for Kawasaki, which is fever more than 5 days, blah, 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 blah. Now, what is the criteria for diagnosing rheumatic fever? First, what is the name of the fit?
The Jones criteria.
Very good. So what is Jones criteria effect?
For Jones criteria, it have several parameters in order for us to diagnose this disease. And for Jones criteria, there must be evidence of recent strep infection, plus with 2 major criteria, or 1 major and 2 minor. For major criteria, there are 5: carditis, polyarthritis, Sydenham chorea, erythema marginatum, and also subcutaneous nodules. But for minor criteria, I found it has varies according to books and also recent studies. But most of the time, it comprise of these 6 criteria for minor: fever, arthralgia, previous rheumatic fever, and also according to lab investigation, raised ESR or CRP, prolonged PR interval during the ECG, and also can be presented with leukocytosis.
So this is an important point which I need to inform you, which are very important. Any criteria, okay, and you need to concentrate on that. Any criteria needs stem and the body. Again, any criteria needs stem and the body. I mean by the stem, for Kawasaki disease, I'm going to tell there is a fever for at least 5 days. Unless I suspect atypical, I can diagnose it a bit early. Okay? The second one is the criteria, which is 4 or 5. For rheumatic fever, when I come now, I will say it is a history of post-streptococcal group A beta hemolytic streptococci and either 2 major or 1 major and 2 minor. Or also now they are speaking about atypical or incomplete diagnosis of rheumatic fever. Am I clear? So please, for any score, you are going to diagnose, don't forget what is the diagnostic criteria for eczema or asthma, which is API. Who knows it? Hidayah? What is API? Asthma predictive index. API. Asthma predictive index.
There are two major criteria and minor criteria.
No. I am asking about another. Yes, this is for rheumatic fever, but for asthma, how can I go the asthma predictive index, which has abbreviation as API? Anyone know it?
Children with more than 4 visit episode.
Yeah, you started to get something near. So the at least 3 attack of wheezy chest over 12 months plus. You see, if you read this API, you will find that ILS within 12 months that the child or the baby got 3 attack of wheezy chest with either 1 major or 2 minor. Okay, 1 major, which can be eczema like that, family history. This is a very important. So please, if you got any criteria, don't forget the stem. Subacute bacterial endocarditis. Anyone knows the criteria for diagnosing subacute bacterial endocarditis? It is very important. It has a very important score. So who will be the one of today's presentation? Who will be the second presenter today?
I will be the second presenter for today. But before that, do we need to proceed with the OSCE question for the first?
I'm going just to ask either you or Danielle to prepare some criteria, Jones criteria, for just to go for criteria and try to make a short summary of it. Now we speak just about now criteria for Kawasaki, criteria for rheumatic fever, Jones criteria, criteria for subacute bacterial endocarditis, criteria for asthma, because this one will give you an important view about understanding how to clinically diagnose. Okay. Can we come now to the other differential diagnosis you make and the Kawasaki and the OSCE?
Yes, so for the first differential diagnosis is the measles. The point to suggest measles are fever, maculopapular rash, conjunctivitis, irritability, cough, lymphadenopathy, and also malaise. But the points against for measles are the non-persistent cough, no complete spots on the buccal mucosa, and also the patient harassed already took a vaccination for measles. And next is the scarlet fever. And the points that suggest for scarlet fever is fever, rash, discoloration, exudative tonsillitis, and also vomiting. The points that against the scarlet fever is that there is no scarlatina, which is the diffusely erythematous, or we say it as a sandpaper skin rash. There is no sandpaper skin rash in this patient. And next, I would suspect it as a leptospirosis because this patient have those common symptoms: fever, vomiting, diarrhea, rash, and adenopathy. But there is no history of eating outside from the house, and eating outside of the house, no history of water activity. And next, which is the toxic shock syndrome. As next, okay. This patient had high fever, maculopapular rash, watery diarrhea, non-purulent conjunctivitis, discoloration, also vomiting. But the patient is not hypotensive based on the investigations. And next is, we will proceed to the OSCE.
Okay, so now this is an important lesson to all of us, please. Don't accept a single diagnosis. Okay, From now and then, inshallah, in your work, we must set whatever is the diagnosis is simple and clear in front of you. Okay? Don't accept single diagnosis. If you start by that and you still have, alhamdulillah, a good time now to be graduated, you will ask, this patient, if not Kawasaki, what can be else? This patient may be atypical Kawasaki. If not atypical Kawasaki, what can be else? So when you are going through that, you will be a good practitioner. Because nowadays, the disease itself is not typical like before. When we graduated, I think I was graduated with the edition of Nelson, 1983. If you read for any disease, you will find as if Nelson prescribed the patient in front of you, 100%. With time, with every edition, we started to see a typical presentation for any disease. Even now, which is that pandemic of speaking about the COVID, now there is also new era, okay, for it. And now we are in the fourth attack. Everything may be changed. It may be the patient will not come with chest problem at all. He will just come with some fever, and it may be the chest will be deteriorated very rapidly, like that. So some are presenting by diarrhea. So take care about it. Don't accept one diagnosis. And even if your diagnosis in the top is acceptable, ask yourself, what is the other differential diagnosis? Okay, am I clear? Then you can go now for the other presentation, the OSCE.
Okay, moving on to the OSCE question. So for the first question is, a 2.5-year-old boy is brought with a history of high-grade and continuous fever without chills and rigors for 1 week. The parents deny any history of diarrhea, coryza, vomiting, or headache. Clinically, the child is conscious, irritable, febrile, and normotensive with no neck stiffness. There is conjunctival congestion, crusting of the skin around the lips, and 2 discrete left-sided cervical lymph nodes measuring 2 centimeters in size. His name examination is normal, and the photograph of the child is shown as shown in the slide. So these are 5 questions. So first question is, what is the diagnosis? Second is, name the lab abnormalities that can be found in the blood test. What is the most common cause of death in this patient? What's the drug of choice for this disease? And is meningitis a complication of this disease? So is there anyone who would like to volunteer to answer? Okay, if there's no volunteer, may I have Akila?
Yes, so for the first question, what is your diagnosis? So this can be Kawasaki disease because the patient presented with the signs and symptoms of Kawasaki disease that we have discussed earlier. And then do I have to answer the second question as well?
Yeah, sure.
The second question, name 3 laboratory abnormalities found on blood tests in this condition. So in Kawasaki disease, patient can present with raised ESR, MCRP, leukocytosis, thrombocytosis, very important, and neutropenia as well. And then the third question, what is the most common cause of death in above mentioned patients? So the most common cause of death is basically cardiac conditions. So especially coronary artery aneurysm. Okay, and then fourth question, what drug of choice you would like to give to this patient? IVIG and aspirin, we have discussed earlier. And then the last question, can meningitis be one of the complications? Yes, meningitis can be the complications of Kawasaki disease.
Okay, thank you, Akila. Just to clarify about the fifth question, meningitis is a complication. We call it aseptic meningitis, but it's not common. It's a uncommon manifestation of Kawasaki disease, but it can occur. Okay, moving on to the next question. Okay, an infant presents with a history of excessive irritability and fever since 1 week. He has been under treatment for conjunctivitis for the past 3 days with ciprofloxacin eye drops. The child is febrile and he has a fine rash over his upper chest and his throat and oral mucosa is congested. His liver is 3 centimeters and is tender to palpate. For this question, may I have Rhoda to answer?
Okay, yes. So for the first question, what is the most likely diagnosis? It will be Kawasaki disease because the infant present with fever and then he also have conjunctivitis and also fine rash. And then for what drugs would you use for therapy? It will be IV immunoglobulin as we discussed before and also aspirin. And name one finding on ultrasound USG abdomen. It will be hydrops gallbladder. And then name 4 common differentials for these conditions. It will be measles, scarlet fever, toxic shock syndrome, and also juvenile idiopathic arthritis.
Okay, so that's the answers for this OSCE question. So that's all. Thanks.
Now, your colleague, this question also opened for us another era about thinking of differential diagnosis because this autoimmune disease can share some parts at the end. Because the first question I asked your colleague, what is the mechanism? So he must know that it is autoimmune disease. The era of autoimmune disease is that anyone knows?
Sorry, Doctor, can you repeat the question?
The mechanism of autoimmune disease.
Is it due to the autoantibody?
Good. Continue.
Is it when the immune system of our body attacks its own cells?
Very good. That is the issue. Now, the body now, in case of like an example of rheumatic fever, the patient got group A beta hemolytic streptococci. So the body make a severe reaction against that one. But unfortunately, the immune system became confused. Okay, and think that the heart maybe share the same characteristic of the disease with the group B hemolytic streptococci. So all the body will go to the heart, destroy the valve, destroy whatever. And they can go for the joint, and they can go for the skin, and they can go for the CNS, causing chorea. This is an autoimmune. At the same time, like this in Kawasaki disease, it will come to the heart, but it can come to another area in the body, like skin, like lymph nodes, like that. So that is the issue. Now it is misconfusion of your own defense between the enemy and your own, which is very, very dangerous. That's why using some medication like corticosteroid, even in rheumatic fever, if it is severe and active, we are not only consider antibiotics and aspirin, we must consider corticosteroid if it is active and severe and have carditis, because they used for rheumatic fever to say that it is a dog which like the joints and bite the heart. Even its action is like that. He is just making a liking of the joint. The joint will be edematous and inflamed for short time and fleeting, and go for another one, for another joint, and at the end, there is no destructive. But when it comes to the heart, it will bite it. It will leave. This patient has double aortic. The other patient has double mitral, double aortic. The third one has blah, 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 blah. So it is very important to understand that mechanism and the importance of this corticosteroid, IVIG, which all of this can be. So don't be also looks unprofessional, and if some specialist write medication to the doctor, because I found sometimes patient with nephrotic syndrome and he was prescribed about 45 milligram prednisolone, okay, and it makes like now 9 tablets, and you ask the mother to give her child at the morning 9 tablet corticosteroids. And then they will start to argue about the number, and then argue, oh, this number and this steroid, when they read, oh, it has a lot of side effects. And your now role is to convince them how to accept, and even my goal, how to love this steroids. Did you understand mine? So it is very important to be able to tell them, Mom, I would like to tell you about 40 or 50 years before, no one knows about using steroid on that. And that patient of nephrotic syndrome usually ended by renal failure, and you need to make dialysis 3 times per year, per week, or renal transplantation, which are very difficult. And even if he did renal transplantation, which is curative, he need to continue on autoimmune drugs, the same, but another groups for life. Do you know that any solid organ transplantation, he need lifelong immune suppression? Otherwise, the body will reject that organ, new organ. So it is the same, Mom. He must continue for this autoimmune drugs, which is cyclosporin or whatever, for life. Now, we are trying, after many researches and the medicine, they found if we start corticosteroid early and continue it for at least 1 month until remission, and then got another month and then try to taper it or cut it directly, all this is a very, very, very supportive to the kidney of your child. Then the mother can understand what will happen. At the end, me or the patient must love corticosteroid, and they said, Alhamdulillah, that we have drug like corticosteroid which can suppress my child in about 85%, because still about 15% may still need cyclosporin or cyclophosphamide or another drugs for corticosteroid resistant or dependent nephrotic. So your rule with time is to have a broad mind, how to convince the family to love corticosteroid, which I may ask any one of you, and you can give me lecture in the side effect of corticosteroid. But in spite of this side effect, we cannot live without steroids in our practice. That is the issue, please. It is the same. The patient came to you and tell you, oh, doctor, my child diagnosed with type 1 diabetes mellitus, and he must inject it by insulin at least 4 or 5 times per day. I will give him pre-meal and one at the night, and I need to do blood test many times per day. My child is in bad situation, and what to tell him? Okay, If you fed up, stop it. Akila, are you able to give him this decision?
Yes, doctor.
Are you able to give the father this decision? He can cut the insulin and go rest for a few days?
No.
What will happen?
The complication of diabetes mellitus type 1, like ketoacidosis, more severe.
So within a short time, your child will come in a coma with severe dehydration, with electrolyte disturbance, and if it is repeated with long time, you may get micro or macrovascular changes which can affect many organs in the body. That is the issue. I am preparing you not to be a doctor by name. Yes, you are a doctor, but you must do a lot of job. You must do a social job. You must be able to convince the one in front of you about the benefit of that one. So you must know how to do communication, how to guide the other to the best of them. Is it clear? So you must say, Alhamdulillah. I would like to tell you before 200 years ago, when someone got diabetes mellitus, okay, it happened with one of the like king or someone. So they just used to send someone to test the urine for him. There is no test. If he found the urine sugary, they will tell him be strong. It is about 1 or 2 year maximum. You can stay with us. This is for type 2, of course, because it will start to good comas and like that. They don't know, but now we know that there is a problem with the insulin and we can give you some drugs. For the small one, type 1, we need to give only insulin. But now we are thinking about insulin pump. We are thinking about, it is not started yet in many countries, like insulin, like pancreatic transplantation. So there is medicine with you, inshallah. Now you will be graduated 2023 or like that. I hope within 20 years, if you are got these concepts, your role as a doctor, your role as a researcher, your role as a social, your role as how you are sleep and awake thinking what to give your patient, you may make new era. We are not in waiting for another country, developed country, to give us a piece of knowledge every time. We must be the one. If you are thinking just to be a doctor and see a limited number of patients and collect a big number of money and like and so you are doing a wrong decision. If you did a new era in the development of medicine, you are giving a reward from Allah. If you are doing what is this comprehensive job, this is the way that you will be a good professional with time. So please don't forget about that. Don't forget about your role for the future, for your country, for your ummah. That is the way. So start strong and continue strong, inshallah. Okay, second case, hoping it will take shorter time now.
Okay, so I will proceed to the second case. So I will be, my name is Naizata Amira and I will be the doctor in charge, and Puan Akila is the patient's mother. Okay, so Puan Akila, can we proceed to our session?
Yes.
Doctor.
Okay. Okay, so Puan Akila, may I know your daughter's name and age?
Her name is Rania, 7 years and 10 months old.
Okay, so may I know why you come to the hospital today?
So I come to the hospital because Rania experienced pain on lower limb and rashes for 1 day.
Okay, so the main complaint is your daughter have pain and rashes on the leg, right?
Yes.
Okay, so may I ask more on the pain? So so the site of the pain is at the lower limb. Do you know the specific area of the pain?
Um, I'm not sure because she didn't mention the specific site.
Okay. When does the pain occur? Is it throughout the day or just specific time?
Um, it's like sudden and continuous.
So for the pain, is it occur when she walking?
Yes, she did have some complaints, some problem with walking.
Okay. Aside from the pain, you said that the patient have rashes on the leg. So may I know when did the rash start?
So the rash actually start together with the pain.
Hmm?
And it started from the upper limb, and then it spread to the lower limb.
So okay. How the rash look like?
The rash is actually red or pink in color and a bit raised.
Okay. Does the rash look similar as the same how it initially erupted?
Oh, I'm not sure about that.
Okay.
I think it's just the same.
So the rashes not change over the time, right?
Yeah.
Okay. So did the rashes go away and return, or it just persists throughout the day?
Yeah, it's persistent.
Okay. Does the rashes itchy?
Yes, she did complain that the rashes is very itchy and painful.
Okay. Does it affect her sleep activity?
I'm not sure. I don't think so.
Okay. Rather than the rash is itchy, is it painful? That your daughter complained, yes. So is there any bleeding or discharge come out from the rashes? No. Okay. Do you notice the rash is appear after she has contact with something or after eating something?
No.
No. Okay. So she doesn't have any allergic before to the drug or any food?
No, she don't have any allergy.
Okay. Okay. Does Rania experience any another symptoms such as abdominal pain?
Yes, she did experience abdominal pain. Yes.
Can you elaborate more on the abdominal pain?
So actually, the abdominal pain is not specific, like no specific site. It's generalized. And she do have vomiting as well. And the contents of the vomitus is just some digested food particles.
Does she experience any diarrhea?
Diarrhea, no diarrhea, but she did pass out black stools for 3 days.
Okay. Okay. Do you notice did Rania have fever?
No fever.
Any loss of appetite or loss of weight?
No.
Do you notice any swelling, such as around the eyes or around the joint?
No.
No. Okay. Does Rania have symptoms such as runny nose, cough, or rapid breathing? No. Does you notice any bruises on Rania before?
No bruises.
No bruises. Does she complain or you notice any change in urinary frequency? Evidence of faulty urine or blood in urine?
No.
So does Rania have any known medical illness before?
Actually, this was actually forced hospitalization. So she was first hospitalized due to afebrile seizure when she was 1 year old. And then when she was 5 years old, she was hospitalized for the second time due to fever as well. And then the third hospitalization was due to gastroduodenitis, which was diagnosed 2 to 3 days before this current admission.
Okay, so may I ask is she has any ectopy or eczema?
No,
No, any asthma?
no
History?
asthma. Yeah.
So may I know about how Rania was delivered, and is there any complication during pregnancy or after delivery?
So prenatally, I actually had gestational diabetes mellitus, and then throughout my pregnancy, okay, actually Rania was born via SBD at term at 38 weeks, and then she was her birth weight was 3 kg, and then postnatally she had mental jaundice for about 2 days.
Okay. Okay. I would like to ask for do you breastfeed Rania, and up to what age?
Okay, she was exclusively breastfed until 2 months old, and she started weaning when she was 6 months old. She is actually a picky eater, and she dislikes spring vegetables.
Oh, okay.
Hmm.
Okay. Do you notice any problem with Rania developmental, or does she perform well in school?
There's nothing abnormal about her growth, and her academic performance is good, and she is also active in sports.
Okay. Um, does she take any traditional medication or any supplement before?
No.
So she not on any medication, right?
She is she took syrup omeprazole 60 milligram twice per day, if I'm not mistaken, because of the gastroduodenitis.
Okay.
Mm-mm.
Okay. So does Rania complete the Malaysia vaccination program at schedule?
Yeah, she took all the vaccine according to the schedule.
So may I know how many siblings that Rania has?
She has 4 siblings, and she is the third one.
Okay. Does her siblings have has any medical illness before?
Actually, his brother, 14 years old, has been diagnosed with Schwanning purpura when he was 18 years old. But he actually didn't experience any abdominal pain and vomiting during that time.
Oh, is there any bleeding disorder in running in your family, such as hemophilia? Okay, may I know where do you live?
I live in Simpang Padang Siol, Jeratot, and the house is occupied by 6 people.
Is it a dengue prone area?
No, it's not a dengue prone area.
There's no recent fogging or
no fogging.
Okay, may I know is Rania recently go to jungle activities or any traveling history before?
No.
So anything you would like to complain or add when Atila?
No, I think that's all.
Okay, is that all? So we will end our session. Thank you, Puan Akila, for your cooperation.
Good. Yeah, and this presentation is better regarding the, you are not doing it as closed question. Please don't use closed question. Usually we need to make mixture of open and closed question so the patient can give a chance to express something. Otherwise, if you are doing like putting the patient in like legal situation, answer yes, no, you may miss a lot of knowledge. So you must open some question. Of course, you must do good introduction and greeting and smiling, and even you can try to sympathize if the patient looks affected by some symptom or some situation of the patient. This is our job. We are not mechanic or robots doing a certain job or are dealing with the soul, which are very important. It may be if the mother or father themselves are sick, they can tolerate. But for their child, they are more affected and more in trouble. You know that one. This is a feeling from Allah for every parents. So can you give me your diagnosis?
Okay, the probable diagnosis for the patient is hinoxidine purpura because the patient have rashes to the lower limb and also pain to the when walking, most probably arthralgia, and the patient have obvious palpable purpuric rash, and also, although the patient have no fever, and okay, and the patient also have the patient also doesn't have any history of bleeding disorder in the family or autoimmune disease.
So how can you prove that?
We need to based on the diagnosis criteria for diagnosis of hinoxidine purpura, which is the first one is the purpura is palpable, the lesion is raised and palpable, and there's no evidence of thrombocytopenia. So we need to send for full blood count to look at the platelet count. Okay, and also the second criteria which is bowel angina, and it will cause acute or diffuse abdominal pain. And the third one is diagnostic biopsy, which is we will take any biopsy for the skin or kidney if the manifestation affect the kidney, and we look at the histological changes that shows of IgA deposition. And the third one is pediatric age group, which in Narnia is 7 years old, and this HSP is common in 3 to 15 years old age group.
So you may need to tell by other expressions that it is a clinical diagnosis.
Yes.
Okay, so just tell it at the first. So it will make your job more simple.
Okay.
So usually clinical diagnosis, but also it is very important, or however, we need to do some investigations to rule out others. That's why at least the family will understand that this investigation is not to diagnose already done clinically, but we need to rule others, okay? Otherwise, we may tell if the father asked you, so, or the mother asked you, there is no definitive diagnostic test.
Is it you ask what the definitive investigation is it?
Yes. Yes.
The diagnostic or definitive first we can send for full blood count as I mentioned before, and we look for
I mean diagnostic test for HSP.
Diagnostic test for HSP is biopsy. We can take from the skin, the rachis part, and we look at the evidence of vasculitis and also IgA deposition.
So now we can understand that this is a clinical diagnosis can be confirmed by skin biopsy, which we are not in need, but we are doing a basic investigation for your child and some investigation to rule out other causes.
Yes.
This is a very important. So why this child can be presented by abdominal pain?
From the patient experience abdominal pain because the IgA deposition attacks the mucosal lining of the attack the mucosal lining of the GI tract, and it will cause acute pain, or sometimes it can lead to complications such as interception and also bowel ischemia.
Okay. If the mother asked you, can this disease affect other organs?
Yes, it may affect other organs such as kidney, and this can lead to acute nephritis or kidney failure, but it is a rare complication or involvement.
What else?
Other than that, it also can affect the joint. So the patient will experience pain when moving the joint, which is arthralgia, and patient may also manifest with swelling, periarticular edema, which is swelling around the joint due to the inflammation response to the joint due to the IgA deposition.
So still we can manipulate the knowledge better, is that it? So we said that what type of vessels are affected here?
Small vessels.
So if I were you, I will tell the mother, do you know this is a disease of inflammation of the small vessel in the body? And these small vessels are present where? In every cell and in every organ. So any organ can be affected. But we used to see mainly the symptom in the joint, in the skin, in the abdomen, okay, in the kidney. But even there is some rare cases which can affect the CNS, which can affect the heart, which can affect the genitalia, the gonads. All these are present. So now you will even give the mother hint if she got some abnormal presentation, not to say it is something not related to the disease. Many of the cases which diagnosed in other areas because of they found like affection of the testes, sometimes affection of the CNS, like that. It is very important and documented cases. So we must say small vessels are present everywhere in our body, in every organ, so it can be affected by a lot of them. Okay. Another important point, if the mother asked you, because you told me it is usually it will resolve spontaneously.
Yeah.
So it is okay. I can travel now to any area inside Malaysia and KL like that. So I hope I am not in need of any follow-up.
No. Usually, this disease will resolve spontaneously, but we need further follow-up to look at to check for any complications or any other organ involvement. So the mother needs to come for follow-up, and we will do another test such as urinalysis or lipase, something. And if the symptoms reoccur, the mother need to go to the hospital and check for the. Is it doctor?
Yeah, so that is the most important. No, in spite we know that the results are very good, but we need to follow up the patient for a considerable time, maybe for 1 year or like that, okay? Until we feel safe, we need to follow up him, his progress, has any organ affection, What about his vital sign? What about his kidney function test? If he got any abdominal pain, you must rule out intussusception like that. So you tell him yes, the diagnosis, the prognosis are very good, but this is different from follow-up because even it is a simple percentage can be affection. Your child must be under close follow-up and he must know he's a specialist if he got any problem to come back to him. Is it clear?
Yes, sir.
Okay, so Danielle, if you found this one, what is the nearest differential diagnosis to your mind now?
I would think of thrombocytopenic purpura because of the rashes.
So this is the number one in the differential diagnosis, which is ITP, okay, which are very important, but with different presentation, okay. Akila, other differential diagnosis?
I would suspect systemic lupus erythematosus.
Sorry?
Systemic lupus erythematosus, SLE.
Your voice is not clear, Akila.
I'm sorry, doctor.
Can you increase the volume of your microphone?
Can you hear me right now?
Yeah, better now.
Okay. So I would suspect systemic lupus erythematosus.
What is the criteria for diagnosis?
Based on the clinical findings as well. So there is rash, purpuric rash, abdominal pain, and arthralgia.
Mm.
And then you can confirm it by doing lab investigation.
Okay. Fawaz?
Could it be dengue fever with warning signs? Because of the rash and also abdominal pain.
So, yeah, but what is the missed now?
I'm sorry?
What is the missed important sign here? Arthritis. You don't have arthritis with dengue fever. The apart, yes. Just said, but it is lacking the role of arthritis. Okay. Other differential diagnosis.
Okay, other differential diagnosis would be leukemia, because the patient also have purpuric rash and also arthralgia, but the patient doesn't have any fever, loss of weight, or any signs of anemia, and no lymphadenopathy also.
Yeah, this is an important diagnosis. Even leukemia can cause arthritis, sometimes presented by only arthritis. Any other investigation, Hidayah, especially if you are looking for arthritis and skin rash?
Urinalysis.
No, I mean other differential diagnosis. If you find one patient with joint arthritis and rash.
Meningococcemia.
Okay, so meningococcemia are very important. Okay, it will come with berberic rash and fever and like that. Okay, Ruwaida? Rauda?
Yes. How about infective endocarditis?
Can be infective endocarditis. Aida? Very common. I told you this child has rash. And then he got some joint inflammation. What can be?
Rheumatic fever.
Not rheumatic fever. What is other? Juvenile?
Oh, juvenile.
Chronic? okay, arthritis. Juvenile, we are not said now rheumatoid like that, we said juvenile chronic arthritis, which usually can be presented by many types, either just arthritis or systemic one, which can start by systemic and then good pain or fever or like that. So it is very important to consider all these differential diagnoses. Is it clear? Okay, now we can come to the differential diagnosis and the OSCE.
Okay, for the differential diagnosis, first one is immune thrombocytopenic purpura, such as before, because the patient have a purpurate rash, but the patient doesn't have any bleeding tendency, such as gum bleeding, and the patient also doesn't have history of coagulation disorder, and the patient doesn't have bruising or sign of anemia before. Okay, the next differential diagnosis would be SLE, because the patient also have arthritis, arthralgia, purpurate rash, and also abdominal pain. But the patient doesn't have fever, and also the patient doesn't have a family history of SLE or connective tissue disorder. And the next differential diagnosis is infective endocarditis. Also same, the patient have purpurate rash, arthralgia, and also abdominal pain. But the patient, but on the PE, the patient doesn't have murmur, or there's no predisposing factors such as infection to group A streptococcus. And the last differential diagnosis would be the leukemia, because of the arthritis, arthralgia, and also purpurate rash. But the patient doesn't have fever, loss of weight, and also no lymphadenopathy, and also no bruising noted on this patient. So next we will proceed to the OSCE question. Forgot the last differential diagnosis, which is meningosemia, which is patient have purpurate rash and also pain on the lower limbs, but the patient doesn't have any URTI symptoms or fever. Okay, we proceed to the OSCE question by Brother Ifai.
So I will proceed with the first OSCE question, which the trigger is a 5-year-old boy came to SUSMED presented with fever, rash, and also abdominal pain for 3 days. These 3 differential diagnoses can anyone try for this first question?
I would like to try the differential diagnosis. It could be henoischemia purpura, systemic lupus erythematosus, and also immune thrombocytopenic purpura.
Okay. Can you show the? So there are many differential diagnoses that can be done based on this simple trigger, the fever, rash, and also abdominal pain. For dengue fever also can comes with all of this fever, rash, abdominal pain, which can be also interpreted as a dengue fever with warning signs. Henoischemia purpura also can comes with fever, rash, basically purpurate rash, and also abdominal pain as one of the diagnostic criteria. Systemic lupus erythematosus (SLE) can comes with many types of symptoms, which can be fever, rash. For SLE, it can be many types of rash like petechiae, purpurate, and also oculopapular rash, and also can comes with severe abdominal pain. Immune thrombocytopenic purpura also can come with fever, rash, also purpurate rash, and also abdominal pain if it is due to the immune response to the mesenteric or GIT lining, and also it can be due to the gastrointestinal bleeding. And also Kawasaki disease and also scarlet fever can be the differential diagnosis. However, for scarlet fever, it does not come with abdominal pain, and Kawasaki disease, we need the fever to be at least 5 days. So it still can be one of the differential diagnosis. Okay, so the second one, second question, during physical examination, it turns out that the rash was palpable, purulent in nature, and also predominantly present at both lower limbs. So what is the most likely diagnosis as for now? Anyone?
HSP.
Yes, not shoreline purpura. Because for HSP, the rash, it will be palpable pupillate rash, and with signs of without thrombocytopenia, which predominantly present at the both lower limb predominantly. And what is the diagnosis criteria for the disease measure of which is the HSP? Now that.
Palpable purpura with lower limb predominance. In the presence of one or more of the following that are listed in any biopsy showing predominant IgA deposition, arthritis or arthralgia, and also renal involvement such as hematuria or proteinuria.
So this diagnostic criteria was released by the International Conference in 2006. The diagnostic criteria will be purpura without the presence of thrombocytopenia. Unlike ITP, in thrombocytopenic purpura, there will be thrombocytopenia. For HSP, purpura with lower limb predominance in the presence of at least one of the following, which is diffuse abdominal pain, just like in the trigger, any biopsy showing predominant immunoglobulin A, IgA deposition, arthritis, acute or any joint or arthralgia, and also can comes with renal involvement if there is presence of any hematuria or proteinuria. So that's all for the first OSCE question. So to the second one, OSCE number 2, a 6-year-old boy presented with pupillate rash in his lower limbs and hematuria. So for the first one, state 2 possible characteristics of the pupillate rash during physical examination. One can try.
I would like to try.
Yes, sure.
The possible characteristics is the crash will be palpable and no blanching, and also reddish purple in color.
Yes, correct. So in this most likely for the diagnosis is shoreline purpura, and the rash will be palpable and non-blanching, because non-blanching refers to the underneath vasculitis under the skin. So it also can comes with non-blanching. For unlike other disease, it can be blanching and also non-blanching. For pupillate rash, it basically the appearance will be reddish purple in color, or also it can be in red spots. But in HSP, it can be comes with reddish purple in color, red spots, or light appearance. And second one, name one invasive procedure that can be done for us to make a diagnosis and state the reason.
Kidney biopsy. The reason is to detect the presence of glomerulonephritis and to look for any deposition of antibodies.
Yes, true. But in this basically HSP, also known as IgA vasculitis. So kidney biopsy can be done as one of the invasive procedure, and basically we want to look if there is any glomerular involvement, glomerulonephritis, and to look for the position of antibodies. And also based on the trigger, the patient comes with hematuria, so we can do kidney biopsy to detect any vasculitis in the kidney. And one of the complications for HSP is basically the glomerulonephritis. And the third one, HSP is characterized by the position of which antibodies in the blood cells, blood vessels.
It will be IgA.
Yes, correct. Because HSP also known as the IgA vasculitis. So there will be autoantibodies and also immune response towards the vascular system, which can be in many organ, and also can cause onto the kidney itself. I think that's all. It's on the first key. Thank you.
So before we finish our meeting, I will just confirm again to you that always don't think in one diagnosis. Think the other differential diagnosis. Always remember that your role in the medicine is not just a doctor who will prescribe medication and goodbye. You usually, in most of the chronic cases, you are the coordinator of the multidisciplinary team. So you must know your team. You must make use of them. Even you must be the good support for the family, okay? And you must convince them to do this test, to do this lumbar puncture, to put this steroid, to like that are very, very important. The other thing, don't miss an important warning signs. Okay, I think is Zati and Daniel will present for you the criteria for diagnosis of some diseases, okay, which are very important to us. So if you found some collection, you must ask yourself, what is the results, okay, which are very important. The other thing, to find a purpuric rash, you must stand up and ask yourself what is the cause, because it can be something dangerous. Starting from Hinchell line purpura, going for ITB, going for leukemias, going for that. So you must ask yourself, what is the probable diagnosis? And if you pick one thread, you must continue to come to the end. I mean, this patient has a rash, which looks like Hinchell line purpura, so I need to examine the joint. Then I need to check if there any abdominal pain or not. Then I need to ask for another symptoms in the kidney. Then I must ask for other systems, okay? So that is the issue. If I understand the mechanism of disease, I will be able to follow up the patient for every piece of his body, okay? So don't limit yourself, don't limit your thinking, don't limit, I mean, you must have a high index of suspicious. High index of suspicious. Even if you are able to omit this suspicion, but it is better to remember it and exclude it in a base, not because you forgot it, okay? Thank you, and hoping the best for you, inshallah, and see you soon in the hospital. Do you have any question before we can finish?
Doctor, may I ask about our marks for the presentation?
I used to send it to the sister Farah.
Oh, okay. Noted.
It will not be confused between you and the science officer, and you'll find it there, inshallah. But you are doing a good job waiting for your criteria. Okay.
Okay.
Okay. See you inshallah. Assalamu alaikum wa rahmatullah.
Inshallah. Thank you, Doctor.
Thank you, Doctor.
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 Thank you, Doctor.